Welcome to Advance with MUSC Health. I'm your host, Erin Spain. This show's mission is to help you find ways to preserve and optimize your health and get the care you need to live well. Amyloidosis is a rare and life-threatening condition that occurs when an abnormal protein called an amyloid builds up in tissues and organs. It most frequently affects the kidneys, heart, nervous system, liver, and gastrointestinal tract. The MUSC Health Amyloidosis Center of Excellence consists of a team of experts who treat this disease. Dr. Jan Griffin is an MUSC Health cardiologist and a member of the center who sees patients in the Cardiac Amyloidosis Clinic. She joins us today with insight on this condition, warning signs, and treatment offered at MUSC Health. Welcome to the show, Dr. Griffin.
Good morning, and thank you for having me.
Tell us about amyloidosis. What is this condition? How do you explain it to patients?
So, amyloidosis is a multi-system disease, and it can affect virtually any organ or tissue. It results from the deposition of abnormal proteins called amyloid proteins. And when these deposit, it causes organ dysfunction and damage. There are more than 30 proteins that can form amyloid fibrils, and the classification of these is then based on the precursor protein. The most common types that affect the heart are transthyretin amyloidosis, which is also called TTR amyloidosis, and light chain amyloidosis, which is also known as AL amyloidosis. These proteins tend to misfold and aggregate, and they deposit as amyloid fibrils in the tissues and the organs, thus causing damage. So TTR is a protein that is made in the liver. It normally carries around thyroid hormone and vitamin A. Light chain amyloid results from the growth of an abnormal population of cells in the bone marrow, and these are plasma cells. These produce proteins, which are called light chains. Again, these proteins misfold, aggregate, and deposit in tissues and organs in the body.
So tell me about some of the symptoms.
Signs and symptoms of cardiac amyloidosis are typically those of heart failure. Patients may complain of new or worsening shortness of breath on exertion, worsening shortness of breath when they lie down in bed at nighttime, or waking up from sleep unable to breathe, or needing to sleep upright in a chair or a recliner even at times. Many people will also develop leg swelling as fluid accumulates and fluid retention worsens. And sometimes they can also even see a decrease or what they think is a normalization of their blood pressure. Several patients have come into clinic and told me that their physicians have needed to decrease their blood pressure medications because their blood pressure was improving. But this, in fact, can be a sign of cardiac amyloidosis. Patients can also develop atrial fibrillation, which is an abnormal heart rhythm, and it's more common in amyloid patients than in non-amyloid patients. In addition, in certain types of amyloid that affect the heart, the nervous system can also be affected. So patients may notice hand or foot numbness, tingling, or pain. Also a sudden drop in blood pressure, making them feel dizzy or lightheaded. In light chain amyloid in particular, patients may complain of tongue enlargement and bruising around the eyes. So some of these symptoms can be quite non-specific, but should cause the patient or practitioner to consider cardiac amyloidosis as a potential underlying illness. In many of our transthyretin amyloidosis patients, they have a remote history of carpal tunnel syndrome, often involving both wrists, and may have even undergone surgery for that, so a carpal tunnel release. Patients also tend to experience lumbar back pain, so lumbar spine stenosis, which causes lower back pain. And less commonly, we will find that patients have experienced a biceps tendon rupture, which is known as the Popeye sign. So during our first meeting, any of our patients that we suspect with cardiac amyloidosis, we will ask about all of these possibly even remote illnesses or diseases that may have been present and would just increase the suspicion for cardiac amyloidosis.
So then how is it diagnosed?
So initially, patients will present and there will be a suspicion for cardiac amyloidosis. And this is typically based on an echocardiogram showing thickening of the walls of the ventricles of the heart, most particularly the left ventricle, stiffening of the heart muscle, leading to the symptoms that I have mentioned, such as shortness of breath and leg swelling. And other red flags which we may consider, such as bilateral carpal tunnel syndrome, lumbar spine stenosis, biceps tendon rupture, or atrial fibrillation. When we have a high suspicion for cardiac amyloidosis, following the echocardiogram, we will perform a bone scintigraphy scan called a pyrophosphate scan. And this is a scan that can detect the deposition of transthyretin amyloidosis in the heart. It does not diagnose light chain amyloidosis in the heart. If this scan is positive, we still need to rule out the possibility of light chain cardiac amyloidosis because, as I've already mentioned, this is a very rapidly progressive disease and treated completely differently to transthyretin amyloidosis. And we do this by performing blood tests, looking for these light chains in the blood. If the blood tests are normal, then we can diagnose transthyretin amyloidosis just based on an imaging study, this pyrophosphate scan. And then we perform genetic testing to determine if the patient has wild type, which is the aging form of transthyretin cardiac amyloidosis, or has a mutation in the transthyretin gene. However, if the blood tests check for light chain disease are in any way abnormal, this typically prompts us to perform a heart biopsy. This biopsy is necessary in order to ensure that we have the correct diagnosis made so that we treat our patients appropriately and with the correct treatment.
The MUSC Health Amyloidosis Center of Excellence is a multidisciplinary center. Tell me about it, the expertise of members across different specialties, and why patients from South Carolina should come here if they have a diagnosis or symptoms.
So the MUSC Center for Amyloidosis involves a multidisciplinary team, and this includes heart failure cardiologists, electrophysiologists, genetic counselors, hematology and oncology specialists, neurology, and renal, to name but a few. We are familiar with the newest treatment strategies for both TTR and AL, light chain amyloidosis, and we take part in several international clinical trials for the management of amyloidosis, both ATTR and AL amyloidosis. As a group, we meet on a regular basis to discuss our patients and their treatment strategy and response to therapies.
Tell me about the clinic and the different types of cases you see.
So I see a mix of typically transthyretin or light chain amyloidosis patients. These are often referred to me from outside cardiologists or internal medicine practitioners who are concerned about their patients presenting, for example, with symptoms of heart failure, such as shortness of breath, leg swelling, and difficulty breathing on exertion. When I first see them in clinic, it's important to go through a diagnostic algorithm in which I evaluate for both TTR and AL amyloidosis. The reason being is that when we diagnose light chain amyloidosis, it needs to be treated urgently as it is quite a rapidly progressive disease, particularly when it affects the heart. However, TTR amyloidosis is a much more slowly progressive disease, and we have time to educate the patient and obtain the appropriate treatment strategy. Moreover, when I diagnose patients with light chain amyloidosis, I have to immediately involve my hematology oncology colleagues, as this type of amyloidosis requires treatment with chemotherapy. And actually, if caught at an early stage, outcomes are quite reassuring.
You mentioned oncology, and sometimes when people are searching this disease, they see the word cancer. Is it associated with blood cancer? Tell me about that.
So transthyretin amyloidosis is not associated with cancer. It is a completely different disease. Light chain amyloidosis can be associated with types of blood cancer, for example, multiple myeloma. And in addition, it is treated with chemotherapy. There is a standard regimen now that we treat our AL amyloidosis patients with, typically a 4-drug therapy, which patients can obtain in an outpatient setting.
Tell me about these patients that you see. What ages, genders? Is there a typical type of patient?
For cardiac amyloidosis, patients typically develop this disease in their 60s, 70s, maybe as old as their 90s. Patients with light chain amyloidosis are probably a little younger when they first present. They can be as young as their 40s, 50s. Patients with transthyretin amyloidosis are typically in their 70s, 80s, maybe 90s. Transthyretin amyloidosis seems to be more common in men than women. The wild type form of the disease, which occurs, we think, due to the process of aging and maybe damage to the protein due to the aging process, tends to occur more commonly in white male Americans. The genetic form of the disease in the United States tends to occur more commonly in Black Americans. Most particularly, there is a mutation called the valine 122 isoleucine mutation, and this is present in 3 to 4% of Black Americans. Now, it's important to note that not everybody with this mutation will develop the disease. And unfortunately, we're not actually even sure what percentage of people with the mutation develop the disease. But it is Black Americans with transthyretin amyloidosis tend to present a little bit younger than the wild type counterparts. And we will typically find this V122I mutation. There are other mutations that we find in the United States in patients with a genetic mutation in the TTR gene. Some of these are thought to have originated from Northern Ireland, some from Portugal or Spain, but they are much less common than the valine 122 isoleucine mutation, which is thought to have originated from Southern Africa.
Can people be tested for these genetic forms of the disease?
Yes, and when we diagnose patients with transthyretin amyloidosis, we offer genetic testing for the TTR gene mutation to all of our patients. Typically, it won't affect the patient management, whether or not they have a mutation or the wild type form of the disease, which again is that without a mutation and just occurs due to aging. But it is helpful and informative for their siblings, so brothers or sisters who may also have this genetic mutation, or children or other relatives to know this and also then to be able to screen for this mutation themselves.
What happens if these conditions go untreated?
Deposition of amyloid protein in the heart results in thickening of the walls of the heart and stiffening of the muscle. So ultimately, this leads to what we refer to as a restrictive cardiomyopathy. Essentially, this means that the heart cannot relax properly and it cannot fill with blood very efficiently. So this leads to fluid buildup, abnormal heart rhythms, and heart failure ultimately. Unfortunately, cardiac light chain amyloidosis can progress very quickly, and time is of the essence, as such treatment should be initiated as soon as possible, or it can be rapidly fatal in as quickly as 6 months from diagnosis. Transthyretin amyloidosis, since it is a much more slowly progressing disease, gives us more time for diagnosis. And although early diagnosis and treatment does help slow the disease process, it is not as much of an emergency to treat as light chain amyloidosis. Ultimately, if either of these diseases goes undiagnosed, it will lead to progressive heart failure and death.
Well, tell me about some of the treatment options that you offer.
So again, depending on whether patients are diagnosed with light chain or TTR amyloidosis, the treatment options are very different. As I mentioned, AL amyloidosis is treated with chemotherapy, typically a combination of 4 drugs as first-line agents and treated by our hematology oncology colleagues. Transthyretin amyloidosis is treated with either drugs that stabilize the TTR protein or silence the protein. The stabilizers work by adhering to this abnormal protein that has started to dissociate. And by adhering to this protein, it prevents it from misfolding and thus remains in its normal state to continue its normal function. The silencing drugs act by decreasing the production of transthyretin in the liver. And so as a result, there is a much lower circulating amount of TTR in the body. And as a result, any further deposition in the heart or other organs is significantly reduced by up to 90%. The first of these drugs that became available in 2019 was a drug called tafamidis, typically just taking 1 tablet a day, and really is very well tolerated by our patients. The newer agents are the silencing agents, and they have just been approved by the FDA much more recently for TTR cardiac amyloidosis.
You've mentioned several new therapies that are fairly new. Since 2019, this seems to be a really exciting time in the field. Tell me how far you've come with treatments for these patients.
It is a very exciting time. Before 2019, there was really no agent to treat this disease. So unfortunately, when you were diagnosed with TTR cardiac amyloidosis, the prognosis was much poorer than it is now. There are multiple clinical trials which are underway to investigate newer agents. One of these in particular is called CRISPR-Cas9, and this is actually a gene editing approach whereby a single administration of this treatment should decrease TTR production in the liver long term. This is currently only in phase 3 clinical trials, but it looks like a very promising therapy. Of course, there is still a lot of investigation to do regarding this treatment strategy. The other treatment strategy that is being investigated is removal of TTR amyloid from the heart or other organs. Currently, the treatments that we have just stop progression of the disease, or at least decrease progression of the disease, but there is no treatment strategy available that will reverse deposition or reverse the disease process. So there are pharmaceutical companies that are looking into developing agents or drugs that would hopefully extract the deposited amyloid protein from the heart or other organs. I just have to make sure that people understand that that's all for TTR. So for light chain amyloidosis, in the past 10 years, chemotherapeutic agents have really advanced to the extent that prognosis when you're diagnosed with light chain cardiac amyloidosis is much improved. However, given that light chain amyloidosis is such a quickly progressive disease, early diagnosis is extremely important so that patients can get on chemotherapy as quickly as possible.
Another approach, you actually published a study recently investigating heart transplantation as therapy for this condition. Tell me about that and a brief overview of the research that you're doing with heart transplantation.
So heart transplantation can be performed in appropriate patients with light chain or cardiac amyloidosis who have progressed to end-stage heart failure, but also who have minimal involvement of the other organs outside of the heart. In the study we published, we reviewed the outcomes of patients who were transplanted for transthyretin cardiac amyloidosis prior to the availability of agents to treat TTR cardiac amyloid. So the main concern amongst physicians is that the organ which produces the transthyretin, which is the liver, remains following a heart transplantation. As such, the question is whether the transthyretin amyloid will deposit in the new heart and result in the same disease process all over again. We had transplanted 22 patients for transthyretin cardiac amyloidosis, and of these, 12 patients were available for enrollment in our study. Of these patients, no patient had evidence of recurrent deposition of transthyretin in the transplanted heart, either on biopsy or by imaging. However, we did find that 8 of the 12 patients, so 66%, had evidence of transthyretin deposition in organs other than their transplanted heart, specifically the gastrointestinal tract, bones, joints, and their nerves. One of the patients in our study required a walking aid only a few years following their heart transplant, despite the fact that their transplanted heart was functioning perfectly well. As such, it is evident that these patients may continue to have transthyretin deposition, and this may impair quality of life despite a normally functioning transplanted heart. So the question now is whether continuing these transthyretin targeted therapies, such as stabilizers or silencers in this population following heart transplantation for TTR cardiac amyloidosis, will improve quality of life and outcomes in this very specific group.
What would you say to patients who maybe they're about to be referred to the center? Anything that you would like to say to them as they would prepare to come?
So I think the most important thing in preparing for a clinic visit in the cardiac amyloid clinic is to consider questions about the disease that you may have and to come prepared with those questions.
As you said, this is a disease that is pretty rare, but it sounds like there's some really exciting things on the horizon. So for anyone listening who has a form of this disease or a loved one, what would you say to them about the future and what's coming down the pike?
Well, thankfully, we have had great advancements in the treatment of both light chain and TTR cardiac amyloidosis. I do think that prognosis in both of these patient populations has significantly improved, and often patients can feel significantly better with just symptom management. For example, when patients present with heart failure symptoms of cardiac amyloidosis, apart from treatment of the underlying disease, whether it be light chain amyloidosis or transthyretin cardiac amyloidosis, patients often have symptoms of heart failure. And so they require additional treatments to remove fluid And so we make sure that any appropriate treatments are prescribed during the course of their care.
Well, thank you so much for all of the information today. We appreciate your time.
Thank you for having me.
For more information on this podcast, check out advance.muscehealth.org.